Hi everyone, and welcome to this webinar about erectile dysfunction with Professor Sangiorgi. I'm pleased and happy to be here with him. It's really a very good opportunity for all of us to be here in this session that will be for sure something that we can manage in an interactive way. I think that it's the best option to use also the tool that you can see on your screen to post question, to post information requests on the chat. And in case of needs, you can also use the handout of the button to ask to speak directly and ask directly to Professor Sangiorgi. Professor Sangiorgi is the head of the cath lab of Tor Vergata in Rome, Polyclinic University that he reached last January. And I thank him also to be here. And now I leave some, let's say, minutes to present yourself, Max, as it's important. Maybe you can introduce all your background. In case of needs, please do not hesitate to use the chat or the question box to post any doubt, any question, things, and so on. During the meeting, Professor will use also the opportunity to ask your interaction in case of needs or to clarify any doubts. Thank you again, and it's the stage is yours, Max.
Okay, good. Thanks a lot, Dario. I don't know if you can see the slides.
Yes.
Okay. Welcome to this webinar on erectile dysfunction. Again, I'm a professor of cardiology at the Second University of Rome, Tor Vergata. I've been trained in the United States. I was at Mayo from Mayo Clinic in Minnesota, very cold, from 91 to 99. And then I moved back to Italy, where I practiced in Milan as a co-director with Antonio Colombo, that I'm quite sure you know. And then I moved as the chief of cardiology, first in Modena, and then I'm back to Rome because I'm, during the medical school, I've been trained at the Second University of Rome. I have had the opportunity when I moved back to Milan, to start my peripheral interventional program. And at that time, we were, evaluating, erectile dysfunction, only doing, selective angiography of the internal iliac artery. And now I don't know if the Egyptian and Arab friends are cardiologists or there are also radiologists involved in the webinar. However, I do believe that any cardiologist should evaluate the erectile dysfunction business due to the fact that these, as you will see, are patients that we evaluate as outpatient clinic every day. And I'm quite positive that when you will start a program on ED, many people will have fun and make joke on it. So you will be the ED doctor for the other colleagues, and as a cardiologist, you will hear, but why you're doing this? There are so many stuff. There is structural heart disease. There is coronary intervention. Why are you, involved in this type of disease? What I can tell you is that I started 5 years ago, okay, with a robust program. So I established a network with our urologist and andrologist colleagues, and I've been done more than 500 cases. And every week we see between 5 and 7 cases of ED. And so it's becoming really an important part of our cath lab. Due to the fact that erectile dysfunction, it's really a big deal. You have to, think about the fact that this type of symptoms negatively impacts the quality of life, is extremely important for the self-esteem, the male self-esteem. And of course, many male will start to experience depression when these symptoms occurs, and also the quality of life in terms of relationship with the partner, it's very poor. And also for the women counterpart, it's extremely poor. I think that the other thing that you have to realize that there are several myths surrounding ED. The first one is that when it occurs, nothing really can be done. There are pills, but you're not gonna, cure ED. Other male, they do believe that it's to be expected at their age. And other, and especially colleagues, they do believe that most of them are related to psychological problems of male patients, which is true for some aspects, but not true for other aspects. The first thing that you have to realize that sexuality is not a matter of age. So ED is more common in elderly population, but is not a normal part of aging, okay? So you have to be very clear on that. So you probably will know people around you, or people with whom you do have a more confident relation, that at 80 years old, they do have a normal sexual relationship with their partner. So ED is not a normal part of aging. What I would like you to know is the definition, what we are talking about when we talk about erectile dysfunction. Erectile dysfunction is defined as the recurrent inability to achieve and maintain an erection satisfactory for a sexual intercourse, which means that the man and the woman need to be satisfied with an orgasm, okay? Of course, you realize that if you find a successful treatment in patients affected by ED, this will have a very strong impact on the quality of life. What about the numbers? It's a huge worldwide problem. More than 300 million people, men, worldwide are affected by ED. Usually the incidence is between 45 and 70 years old. If you move to the population of patients affected by coronary artery disease, the percentage goes up to 61% when appropriately investigated. And if you are a cardiologist, you can imagine why. Many times people who have experienced a myocardial infarction, they are afraid of performing strong physical efforts, so they refuse to have sex with their partner. Many people are taking drugs like beta blockers or diuretics that can impact also on erectile dysfunction. So we have to discern who is who, but I would like to tell you that these are patients that you see in your outpatient clinic every day. The problem is that if you don't ask, rarely the patient will tell you. There is a chance, of course, probably in your country less than that, because women, I don't believe that will say, if they come with her husband, doctor, my husband is affected by ED. But for sure, if you ask, they probably will reply, yes, I suffer ED. This slide, just to tell you the incidence, we already said that this is the incidence in my country. You can see that you have some form of ED even in younger people, but these are more related to psychological problems, okay? The true organic problem in terms of vasculogenic ED starts at the year of 50 years old, which is exactly the same age when a male patient experienced a myocardial infarction. And actually, to be honest, the ED symptoms is the first alarm sign, very important alarm sign, due to the fact that if you look at epidemiological study with patients affected by ED, you realize that ED comes first, and 3 to 4 years after, then a cardiovascular event occurs. This is the reason why when I teach my resident, I always tell them to ask when they interrogate the patient if they suffer for ED, because it's probably the most important and strong prediction of a cardiovascular event. If the patient tells you that he suffers by ED, you need to investigate the coronary and carotid districts. Now, if we move a little bit on the pathophysiology and the arterial anatomy, you know very well that we are talking about the internic iliac district. And as you will see, from the internic iliac, you have basically 3 big branches, which are the external gluteal, the internal gluteal, either called superior or inferior gluteal, and the pudendal artery. So these are the 3 branches originating from the internal iliac artery. Then, of course, from the inferior gluteal, you do have also branches originating for the bladder, for the prostate. So you will see the first time you may have the chance to see an angiography, you will be confused because there are many vessels, but basically I will try to teach you what are the best projection in order to identify what is and where is the pudendal artery. This is the first thing that you have to know. Second, since you are cardiologists or radiologists, so you're not very aware about how we as a male are done, you have to know that the arterial cavernous arteries are placed in the middle of the cavernous body, and the veins are external between the cavernous body and a very thick tunica, which is called tunica albuginea, which is under the skin. So the cavernous body is in the middle, the vein is outside the cavernous body, and it's between the cavernous body and this very thick structure, which is called tunica albuginea. Why this is important? It's important because if you think about a natural erection, you have to think about a tire, okay? You need first intact nerves, so somebody who starts the airflow. And this is, of course, our brain or some sexual stimulation. So tactile, visual, triggers. This will start the erection with the neurotransmission of the impulse at the sacral part of the medulla. Then the other part that you need is a good blood flow. So a kind of compressor tubing, if you think about the tire and how we should inflate the tire. You need also an intact cavernosal tissue, so a sort of good tire, and you need the ability to block the venous output from the penis. So you should not have any air leak in the tire, okay? Why I'm telling you this? This is extremely important due to the fact that when you ask if a patient is affected or not by ED, you will have basically three different situations. I will go back on these slides. However, let's move with order. So keep this information in mind. It's very important that you start to investigate if the patient is affected by ED and what are the symptoms. As I told you before, causes of ED. You see from these slides, 40% are vascular, okay? So primitive atherosclerosis of the pudendal artery. Then 30% of patients are diabetics. So 70% of erectile dysfunction patients have either a primitive atherosclerosis in their pudendal districts, and 30% have diabetes, which means endothelial dysfunction, which means again atherosclerosis and some neurological problems. Another part, 15%, so we are up to 85% of the patient, 15% are related to medication. We discussed about that, beta blockers for cardiologists, diuretics for cardiologists. They are usually related to ED. It's also very common that antidepressant drugs are related to ED. Then a minority of patients, the ED is related to pelvic surgery, so prostate, for hypertrophy, so or adenoma, so cancer. If they don't do a nerve sparing technique, they will end up with an ED, which is related to the damage of the nerves. And then you will see that there are other causes, but are really the minority. The other thing that you have to know, which is also very important, is that the efficacy of the pills, the blue pills, the PDA5 inhibitors that the urologists and andrologists administer to ED patient, the patient, 50% of the patients, they have a suboptimal response. And there is a relevant side effect in up to 25% of patients. So many patients, they suspend the treatment due to the fact that they have flush, they have headache, so it's not really well tolerated, okay? Which again, this is the first line therapy for urologists and andrologists. After a patient goes back to a neurologist saying that they cannot take drugs due to the fact that there is a terrible headache, 30 minutes after they take the pills, you know, the urologist usually, they will recommend another technique, which is in their guidelines, second line technique, low intensity shockwave therapy. So it means ultrasound in order to increase the neovascularization of the cavernous body. Again, is in their guidelines. I dare you to follow a patient after the low intensity shockwave therapy. You know, only few cases will say, yes, I had an increase in the performance after this therapy. So basically, it does not elicit a really good response. The third line therapy for urologists is penile implantation, which means end of the story, due to the fact that in order to implant a prosthesis, they have to destroy the cavernous body to make the space for these cylinders that they have to implant inside the penis. So this is the urologist and andrologist situation. Having said that, I do believe that we should always ask, as a cardiologist, if the patient is sexually active, or, you know, if you want to go lighter, if they have any sexual concerns or any sexual problems that we would like to discuss with us. Then there is another problem, you know, that many patients will not tell you if you don't ask, and this is the reason why I told you, you should always ask, due to the fact that they have a sense of embarrassment. There is a societal taboo against an open discussion of sexuality. They also feel not really optimistic about the outcome of such discussion due to the fact that nothing can be done, as I told you at the beginning. And of course, they don't think that a cardiologist should be, you know, involved in this sexual problem, due to the fact that they don't know that ED symptoms onset, it's approximately 4 years before a cardiovascular event. So they do not connect the ED problem with the cardiovascular and cardiology disease problem. Then for us, of course, there is always a time constraint during the visit. There is a deficit in communication skill. We don't know what to do if a patient tells you, yes, I do have a problem. Should we then refer back to a neurologist? Should I recommend a PDE5 inhibitors? You know, there are problems also for us. But what you need to know is that basically are these 5 questions. First, whether the patient has difficulties in obtaining an erection, whether the erection is suitable for penetration, whether the erection can be maintained until the partner has achieved an orgasm, whether ejaculation occurs, and whether both parties experience sexual satisfaction. With this question, you are exploring the capability of having an erection, which means the arterial part. You are exploring the capability of maintaining an erection, which means a healthy cavernous body, which is able to increase its volume and compress the veins against the tunical bugynia. So the erection is maintained. it's the tumescence, it's enough for penetration, and the male is able to maintain the erection until either himself or the partner has an orgasm. The ejaculation occurs, so there are no problem with the prostate, and also there is a combination of sexual satisfaction due to the fact that the relation, the psychological environment is healthy with the partners. So basically, we are talking about tumescence and penetration problem, and this is the arterial insufficiency. We are talking about erection maintaining problem, and this is related to a venous insufficiency. And some patients will experience a mix of these two situations. So they will say the erection is not strong enough as it was 10 years ago, and I'm not able to maintain the erection, which is not strong enough. Now, urologists talk about venous leakage. In my experience, is not true. So you should go a little bit deeper in, asking the patient, due to the fact that a primitive venous insufficiency is something that the patient will experience when he's in the adolescent state. So at 16 years old, when we as a male, we start to masturbate, auto-stimulate, ourselves. So the patient will tell you that he noticed that he could not maintain the erection when he was 16 years old. It's not something that occurs after a normal sexual life at 60 years old. If he has an erection maintaining problem at 60 years old, which was not present at the beginning, it's only because they have arterial insufficiency. So the cavernous body does not increase the volume enough in order to compress the vein. And this is the reason why they're gonna tell you, I have tumescence problem and I'm not able to maintain the erection, okay? So as you see, only with normal interrogation of the patient, you will be able to understand as an interventional cardiologist if the patient has an arterial problem or a venous problem, which is extremely rare, 1 to 3%, a primitive venous insufficiency. Of course, the question that I told you are collected by a questionnaire, which is called IIEF-5, International Index of Erection or Erectile Function, 5, due to the fact that there are 5 questions. Of course, there is a score. This is very important for you, that every time you ask, you record the score, due to the fact that when the patient will come back after your treatment, you can compare the score before to the score after the treatment. Per protocol, we usually treat only moderate to severe ED, okay? We don't treat the slight ED. So somebody who has a score between 17 and 25, okay? We treat only scores of 12, 13, or 6, 7, 8, 1, 2, 0, okay? Because there are patients also with a 0 score on these 5 questions. And you can find the questions on the internet. You know, it's the most utilized international score on erectile function that you can find. Then, of course, as a second diagnostic line, you should submit the patient to a dynamic Doppler. The dynamic Doppler basically is the measure of the flow at the level of the pudendal artery. It's usually measured in 2 times, basal and after PDA5 or prostaglandin injection into the cavernous body. Of course, 10 minutes, 15 minutes after the injection of prostaglandin into the cavernous body, the flow should increase. So an inflow insufficiency, so an arterial problem, is demonstrated by a peak systolic velocity less than 25, an end diastolic velocity less than 5, and a resistance index greater than 0.8. This is the definition of arterial insufficiency. On the contrary, venous leakage, you will have a normal peak systolic velocity, so a flow that increases up to 50, 60, 70 centimeters per second, an end diastolic velocity which is greater than 5 because there is a venous leakage, and a resistance index less than 0.8. And then you may have a mixed pathology. This is usually done by urologists and andrologists, this test, but I'm quite positive that you as a cardiologist, you can perform on your own this type of test in your outpatient clinic, due to the fact that the puncture of the cavernous body is very, very simple. So I will recommend you to be autonomous. However, at the beginning, it's better, to establish a network with the urologist. So try to work together with them. But this is the test that you should do. I told you about the anatomy of the penis. As you will immediately realize, is that not all men are created equal. So there are some variables on the anatomy that I told you. Internal pudendal artery originating from the division of the gluteal, inferior or superior gluteal. There are some cases where there is a posterior origin. There are some cases where the internal pudendal artery originates from the obturatory arteries. So my strong suggestion is to establish a network with your radiologist, because at the beginning it's very important to understand where you should go and to understand the anatomy. As you clearly see from these images, you immediately realize that angio-CT will give you a fantastic view of the pelvic district, okay? Having said that, you should look at, in terms of atherosclerotic disease, zone 4 and zone 5, okay? These are the most common sites where you will see atherosclerosis, so vasculogenic organic erectile dysfunction. And these occur so in the mid part of the pudendal artery before the bifurcation into the common penile artery and the bulbouretral artery, which gives irroration to the gland, okay? So you have the common penile and the dorsal penile artery, which will enter into the cavernous body, and you then have the bulbouretral artery, which gives irroration to the gland. This is the anatomy. And these slides summarize, as you can clearly see, the incidence of atherosclerosis in the distal internal pudendal artery and in the common penile artery. You see the majority of the atherosclerosis is found in the zone 4B and zone 5A. Okay, it's unusual to find in the zone 5B, and even if it could be present, it will be extremely difficult for you to reach due to the fact that we are talking about arterial beds that are less than 0.5, 0.8 millimeters, so very small arteries. And there is a big chance of perforating if you inflate a balloon and create a fistula due to the fact that the veins counterparts, they usually are attached to the cavernous artery at that level. What you will see basically at the selective angiography is this. Look at the panel A, for instance. There is the internal pudendal artery. You can clearly see the division, the distal division in the common and bulbo-urethral artery for the gland. You see another thing that is shown in this slide. It's a CO2 angiography. The reason why we perform CO2 angiography, which is depicted in panel B and panel D, is related to the fact that some patients, they have normal pudendal arteries, but they still have erectile dysfunction. Now, the urologists believe that there is an increased fibrosis of the cavernosal body. And this is the reason why we perform CO2 angiography, due to the fact that CO2 is a gas. So it could be more available for diffusion into the tissue. And so you have a very strong stain with CO2 in case of healthy cavernous tissue, like in panel B. If you see in panel D, you do have a CO2 injection, but there is no stain of the cavernous body. And you see in panel C, again, the pudendal artery are free of disease in this case. So perhaps this is a case where the microcirculation is gone for endothelial dysfunction. So it's like a myocardial infarction of the cavernous body. It will be very difficult, to get back to a normal erectile function in this patient. So I'm telling you, if you see a normal anatomy, then perform a CO2 angiography if you want to have the complete picture of these patients. Now, when you perform a selective angiography, you see here our catheter is placed in the common trunk, so in the gluteal trunk, a distal part of the interna iliac artery, and you have, when you perform the angiography, you have three major branch. Here you do not see the internal gluteal, but you have the external gluteal here. You have the pudendal artery, which is this one, which runs around the bladder, okay? So what I usually do, first I do an AP projection in order to have the exact anatomy. So when I see an artery that distributes in the middle part of the bones, okay, in the middle part of the body, because the male organ is here. Then I move to an homolateral 45-degree caudal, which will give you this image. So the pudendal artery runs around the bladder and then distributes in the middle part of the body. Okay, these are the two projections that you have to utilize. If you have doubts, you can move to an homolateral 45 cranial in order to better visualize the distal part. So you will see the cavernous body very well in the cranial 45 homolateral view. But again, at the beginning, the first 20 cases, do CT angiography before bringing the patient to the table. It will give you an exact view of the peripheral district. You can choose the best projection in order to visualize the pudendal artery and to see if there is atherosclerotic disease in this district. So again, in order to recap and then to move to the interventional part, I think that cardiologists should always take sexual history during our patient examination. The rule, if we don't ask, they don't say, it's always true in this setting. IF5 and questionnaire and dynamic Doppler examination are sufficient to make diagnosis of vasculogenic erectile dysfunction. And then angio-CT and CO2 angiography should complete the diagnostic track and give a detailed information on atherosclerotic disease presence and healthy status of the cavernous body in this setting. So this is what you need to know in order to clarify the picture. Then let's talk about what we are doing, why we have to treat this type of disease with intervention. And as you will see, we're going to utilize coronary devices and coronary techniques. So when you go and talk to a neurologist or to an andrologist, they should know that, for instance, this is a very big study where they clearly demonstrate that there is a correlation with the coronary artery disease and the internal pudendal artery atherosclerotic disease. Okay, so patient with suspected coronary artery disease and affected by ED, poorly responsive to PDA5, they usually have atherosclerotic disease in their internal pudendal arteries. Okay, so this is your main credo. So if a patient presenting with ED that tells you that he has taken the blue pill, he has increased the dosage, and he does not respond anymore to what he was used to respond 2 years ago, well, when you bring the patient to the table, evaluate both the coronary artery and the pudendal artery. I'm telling you this, for sure, the urologist and the andrologist will know that before giving the blue pill, the PDA5 inhibitors, they will request a cardiovascular assessment to you, because they know very well that there is a very strict correlation between coronary artery disease and ED, okay? So these are patients that you probably will see to perform a stress test, okay? Because the urologist would like to be on the safe side that you evaluate the patient before giving a PDA5, which will cause an increase in the vasodilatation, so it's risky if the patient has a coronary stenosis. So they would like to know cardiovascular status of the patient, okay? So it's probably more for you who are not acquainted with this type of symptoms to understand that there is a strong correlation. The urologists and andrologists will know. But again, these are patients that we see in the outpatient clinic every day. The other nice part that you have to know is that when you move to guidelines, and these are the guidelines of urologists, you have PDE5 inhibitor oral therapy, which could be sildenafil, vardenafil, tadalafil. Then they move to penile injection, so the cavernous injection. Then they move to the intrauretral suppository. Then they move to vacuum constriction device. And at the end, they move to penile implantation. This is what they say. First line PDA5, second line intracavernous injection and intrauretral injection, third line penile prosthesis. There is no mention of percutaneous intervention for vasculogenic causes, which, as you have seen, more than 40% of the cases. So we need to do education to our colleagues, urologists and andrologists. Well, there have been a previous, attempt to treat by stent or balloon. The first study was a study from Harvard University. Then trial, 383 patients enrolled. You see stenosis in approximately 35% of the cases. Very important restenosis at 6 months follow-up due to the fact that all patients were treated by drug-eluting stent. These are very small arteries. So with the drug-eluting stent, the Zen trial experienced more than 45% of binary restenosis at 6 months follow-up. Then there was, back to the future behavior. Okay, so drug-eluting stents, they're not working. Let's try with plain old balloon angioplasty. Perfect one study, binary restenosis, 41%, still very, very high. We arrived 2015. A group in Taiwan, they did a randomized study, drug-eluting balloon, which at that time was a mature technology. We started to utilize the technology in 2004, 2005, as you remember. So in 2015, the drug-eluting balloon market was mature versus drug-eluting stent versus plain old balloon angioplasty. You can clearly see that the number of patients enrolled in the drug-eluting stent group was less compared to the other group due to the fact that the drug-eluting stent group was early terminated due to a high restenosis rate, greater than 60%, okay? Having said that, let's say what happened with the drug-eluting balloon. We do have a clinical success rate 8 months, very high, 85% clinical success rate at 6 months, with a binary restenosis rate approximately 26% at 6 months, at 8 months, sorry, at 8 months. in the perfect tree. So we started to utilize this technology, and indeed there are several experience now with this technology. One of the latest is my experience that was published in 2018, and you can know very well the DCB business. So what we need in order to have a good response with drug-eluting balloon. We know that sirolimus is indeed different from paclitaxel. It's the cytostatic, so it's not cytotoxic compared to paclitaxel. So we have had, as an interventional cardiology community, much better results with the sirolimus analogous family compared to paclitaxel. And as you know, we almost abandoned paclitaxel as a drug-eluting stent. The mode of action is completely different. The margin of safety of sirolimus is much wider, as well as the therapeutic range. And of course, the market acceptance of sirolimus is quite positive compared to paclitaxel, especially with the drug-eluting stent business. These are, some, the meta-analysis on paclitaxel with increased mortality, which was discussed. I'm not gonna, talk about that. But let's talk about the sirolimus eluting balloon. This is a very elegant technology, the one that Concept has put it together. Basically, the problem of sirolimus is related to the fact that it's not a lipophilic drug, so the drug does not cross the endothelial barrier. It's not like the paclitaxel, which is lipophilic. It's lipophobic. So sirolimus needs to be encapsulated. It's encapsulated in a lipophilic substance, like phospholipids. And indeed, the drug carrier utilized on the Magic Touch drug-eluting balloon are phospholipids. So the phospholipid encapsulate the submicron particles of sirolimus. They are able, with this bonding, to be to cross the intima layer, and then the carrier dissolves, and the sirolimus is released in the arterial wall. This was a very elegant paper which proves the concept. As you can see, these are sirolimus particle stained with a fluorescence substance, and you see that 60–70% of sirolimus, which is the upper panel, at 1 hour are above the internal elastic lamina. At 3 days, the sirolimus is below the internal elastic lamina. As you can see, at 7 days, sirolimus distributed the lowest panel in the media layer and in the adventitial layer in this immunofluorescence scanning microscopy. There are other sirolimus eluting balloon that you will find now on the market. However, we have to know that the only one who has an ED for the market in the setting of erectile dysfunction is indeed Concept Medical. And you will see on the box that you will have the Magic Touch, which is the coronary balloon, and then the Magic Touch ED, which has the approval for erectile dysfunction application. This is a registry that we are performing in Italy. You can clearly see, to give you some results, you can see that are very strict criteria. So we are treating patients affected by ED, not responding to PDA5 at least for 1 year, presenting with an IEF score less than 12 and a Doppler, dynamic Doppler with a peak systolic velocity less than 20 centimeters per second.
I think that there is a network issue. Just a sec. Max, I think you're freezed. Okay. Sorry for the inconvenience we are solving. In the meantime, I saw that there is a question on the question box. If there are any other questions, please do not hesitate to post, just to allow them to collect all these and then ask directly to Professor Sangiorgi. Just a sec. Professor is calling. Is going in again. This is one of the things that we would avoid if we can have a physical meeting for sure. So sorry for this inconvenience. In the meantime, I invite all of you, if there are any, not only questions, but suggestion also to have a more effective message that can help you in understanding the different type of things regarding anatomy, regarding procedure, to do not hesitate to ask. If any one of you would like to directly speak, can use the button to put the hands up, and then I will open the microphone to allow to discuss this point. And Concept Medical, I know that some of you has met our local distributor or directly our marketing people, and we would underline how important this type of technology that allow to have good results in terms of angioplasty performed on pudendal artery. Thanks to Professor Sangiorgi, we are day by day improving also the result in terms of the scientific things. In this moment, I think that then Professor Sangiorgi is going to talk about also this point. There is one study that is called Suasion that is ongoing and is almost near to the final enrollment phase. And the next step is for sure the randomized controlled trial that hopefully will start early next year, where Professor Sangiorgi is involved and there are other countries that are there. And I think that the professor is connected again. Let's check. Max, are you there? Okay, let me fix. In the meantime, if you want, you can take 5 minutes of break, and we will solve the problem soon. Okay, we fixed the problem. So Max, if you want, you can turn on your camera and your audio.
Hear me?
Yeah, we cannot see you, but we can hear you.
Okay, now you will see me. And can you see me?
Yeah, we see the email.
And now we should be able to reshare. Can you see the slides?
Yes.
Okay.
In the meantime, as there was one question on the box before starting, if you want, maybe it's a part of the next step talking, but there is one doctor that is Azim Kamis that is asking what is the best image technology for the diagnosis?
Oh, angiography, for sure, angiography. Due to the fact that, you know, the radiologist will tell you that distally is extremely difficult to visualize the distal part. On the other hand, you should know that it will be fundamental for you to, at the beginning of your experience, to do a CT angiography, due to the fact that you have to understand where is the pudendal before you bring the patient on the table. You know, first time you will be completely confused. There are so many vessels that you don't understand who is who. Or, you know, Dario, to establish, you know, of course, and I'm also available, you know, a proctorship, even if I'm in the lab, and if they can, you know, send the image live, we can connect and we can, you know, follow them during the first intervention. Otherwise, it would be extremely difficult. So
Yes,
I'm
can be
sorry.
an option for sure. So maybe according to what are the needs, also as we are going to plan the next upcoming months or weeks, maybe possible live cases with you maybe can make sense also to
Well,
say.
it will give more confidence, if they would see, the different projection, what are the, difficulties in treating the arteries, where they should look, when they should stop, all this kind of stuff will be ideal. To start by their own, if they do not have a peripheral, knowledge, it will be extremely tough, due to the fact that there are different diagnostic catheter. We utilize, for instance, a left mammary catheter or a Bartorelli-Cozzi, due to the fact that sometimes the angle between the external iliac and the internal iliac is very acute. It would be very difficult, to enter the homolateral artery. It's easier contralateral. And this is the reason why, again, I'm recommending at the beginning an angio CT, because at least if they say that the right part has no disease while they see disease on the left part, well, it's better to perform a femoral puncture on the right femoral artery, because you go in crossover and it will be easier to enter the internal pudendal artery from the contralateral part, because homolateral sometimes it's very undulated. Okay.
Yeah. There is one other question related to the imaging about angiography. Dr. Mahmoud Salah asked if is better contrast or CO2 angio.
No, they are complementary. You will not be able, to evaluate or to appreciate the stenosis, especially in the distal part with CO2. You will be able to visualize the cavernous body very well. If they get stained, you will immediately realize, due to the fact that there is an explosion of white, so they get CO2 very strong due to the fact that they are a sponge. So they concentrate the CO2. But what I would recommend in order to do intervention is to do always contrast angiography. What is interesting is that if you are acquainted with peripheral angiography with CO2, so if you do limb salvage for diabetic foot, you know that when you inject CO2, the patient experiences pain in the legs. In this district, no pain. You can do CO2, they do not have any pain in the pelvic region. So you can go very high with pressure and volume. There is no problem.
And the last question from Dr. Mahmoud Salah again. He said, do you treat both sides in same settings?
This is a very good question. I'm telling you that I try to do complete revascularization due to the fact that, this patient, they know that this is probably the last chance before a penile implantation. If you solve them the problem, I tell you that, for a myocardial infarction, rarely, the patient say, thank you very much, doctor, for what you have done. For this type of intervention, if you solve the problem, you know, they will be thankful for you, to you for the rest of their life. Probably also the wife will thank you. Okay, so I try to be very aggressive, and you know what we usually do, and we can you know stop the presentation for 1 second. You know, we give them, beside the dual antiplatelet therapy, for 3 months, as we usually do. We give them phosphodiesterase inhibitors chronically, so taldalafil 5 milligrams for at least 2 months every day. We give L-arginine, which is the precursor of nitric oxide. So to boost the nitric oxide, to increase the nitric oxide level in the body after the angioplasty. And we give also some antioxidant after the procedure. Due to the fact that the patient needs to be extremely confident. Then we withdraw the PDA5 after 2 months, and then we see how he is performing without PDA5. I can tell you, and this is, you know, I can show you, okay, these are the results. As you see, for instance, at 6 months, you have 70% of the patient which have an IF5 improved by 5 points. Means that they move from severe, they do not respond by definition anymore to PDA5, to moderate, at least to moderate, which means that they will respond again to PDA5. Some patients, they don't need PDA5 anymore. Okay, the Doppler velocity, you have an increase in the Doppler peak systolic velocity at 6 months of at least 10 points in 68% of the cases. So it's like back to normal for them, okay? And this is what we would like to obtain, due to the fact that it may have, they may experience restenosis in the long-term follow-up. Some patient, you know, will be treated again. But you know, when you will talk with them, the last thing that they want to do is a penile implantation. Now, of course, in Europe, in Italy, you know, the penile implants are not recognized by the government. I have no idea in Egypt or in Saudi Arabia what is the situation. So for the patient, you know, the demand is huge and the offer it's very low due to the fact that few centers are performing this type of procedures. Second, if we talk about the diabetic population, despite the fact that the prosthesis, the penile prosthesis, they have antibiotics, especially the 3 components, the new 3 components devices have antibiotics. You know, for a diabetic patient, if something happens, so like an infection, you can imagine that they need to cut. And, you know, it's really game over. So when you talk with patients, the last thing that they want to do is a penile implantation. And so they are basing or their hope in this type of procedure.
So makes sense to access to both, both the
Yeah.
Then there is yes.
These results, Dario, no, I want you to show them. These results are, you know, very reproducible. You know, this is a Swiss center. There are 5 centers, you know, in Europe performing this type of intervention. And you can see that, again, these are the results at 3 and 12 months, 65% minimal cleaning improvement of 4 points at 12 months. Very reproducible. This is what you should tell to your patient. And this is the Viagra study endpoint. This is the New England Journal when Pfizer published the Viagra study. You can clearly see the improvements. It's approximately exactly the same, 66, 64% in the different questions. Okay.
But you should not use the pills for sure if you receive the procedure only in the first period, right?
Yeah. Yeah, absolutely.
And
now, also some authors, you know, just to, you know, give them all the information, they experience some elastic recoil after POBA or drug-eluting balloon. I do believe that this is related to the fact how you perform the procedure. So I'm 56 years old. It's you know, 30 years that I'm doing interventional cardiology. We started with plain old balloon angioplasty at the very beginning. You know, I remember the first Palma shots in US, the Victor and the GR2. So we were, you know, putting some stents very not very common. So we know our age, know how to perform a good plain old balloon angioplasty. So you have to prepare the vessel with a normal balloon, with a semi-compliant balloon, then utilize the drug-eluting balloon 1-to-1 ratio with the artery, keep it inflated for at least 3 minutes, and then go down very slowly. You wait 2-3 minutes. If you don't see recoils, you can leave it like that. I think that this type of experience, you know, are related to, you know, bad angioplasty that they are performing. Okay, this is the recoil that they experience at 1 minute. You see 10 minutes after. And this is, they place the drug-eluting stent.
yeah, there is also one question that maybe can also be connected to what you said regarding recoil, that is related to the dissection. Dr. Vander Aferi, I'm sorry for the pronunciation, is asking what are the risks of dissection and how you will manage a dissection, because we were talking about also stents.
You can have, of course, a dissection that we usually manage with prolonged inflation. If it's a type A dissection, I mean, don't bother. If there is a flow limiting dissection, then of course you can try prolonged inflation. If it's not good enough, for good enough, I believe it should be, you know, 30% residual stenosis, then you place a drug-eluting stent. You know, we cannot do anything different. But very rarely, you know, if you perform correctly the balloon angioplasty, you need to put a drug-eluting stent. You know, we now, as a group, we know very well the anatomy. We treat the CTOs now. You know, for instance, this is again the internal iliac. You have the external gluteal in the middle where the white arrow is. there is the pudendal, and you see we go with samurai wire. We know exactly where we should go. This patient was treated with plain old balloon angioplasty, then magic touch 220 for 3 minutes, and this is the results, after the angioplasty. And on the right you have the IF score. We move from index of 8, so severe erectile dysfunction, up to 22, very light erectile dysfunction. So this guy doesn't take the pills anymore. You may have, for instance, in patient with diabetic, non-insulin diabetic for 22 years, this kind of diffuse disease. If you see in the middle of the screen, you have at least 4 centimeters, of disease. And of course, we, try to treat with drug-eluting balloon, but sometimes it's necessary to place a drug-eluting stent due to the fact that the disease is very diseased, and we have to optimize the drug-eluting stent as we do with non-compliant balloon 2.5. But distally, you see here on the left, there is still disease of the distal part. This is the zone 5A that we were discussing, and this is on the right after magic touch ED. You see how it's improved the distal part. So you have to be wise as usual. If you see that the disease is too much, let me see if well, these are other examples also of coronary artery disease. And again, we have coronary artery disease and also pudendal disease that we treat. As you clearly see here, we place Axience Pro 2.5 on the proximal part. But when we are talking about the distal part of the pudendal artery, well, it's better not to place any drug-eluting stent, but only treat with the drug-eluting balloon. Of course, if you start to do CTOs, you can have perforation. This is for instance cyan black engaging the internal pudendal artery. You have the perforation, but honestly speaking, nothing happens. So you can have complication. Perforation, it could happen. Fistulas are other complication that you may have during this type of procedure, especially if you go very distal and you utilize an oversized balloon. Then you have a distal fistula that you may have to treat with prolonged inflation. And again, this is a CO2 angiography on the left with no opacification, and you do have a normal fibrosis, a normal cavernous body without fibrosis on the right with CO2 angiography. I do believe that if you are able to offer a complete analysis, it would be much better. And I'm finishing here with this randomized study that we are putting together with Concept Medical, where we will have a sham procedure. So we will, have a group who will be submitted to sirolimus-eluting balloon and or drug-eluting stents treatment for the internal pudendal artery disease, and then a sham group who will do only pudendal angiography and then cross-section to the other group to establish if there is any different in the treatment, due to the fact that many colleagues would say that this is only related to psychological. They have done the procedure in order to please you. They will say, no, I'm doing much better. Besides the fact that there is the Doppler, which clearly demonstrates that the flow is increased, we will do this randomized study with the shunt group in order to, put a stone thumb on the fact that this patient have psychological problems, and the ED is related to psychological problems. And basically, Dario, this is what we are proposing now. I'm part of the Italian guidelines that will be published actually in May of next year. And so we're going to move from the first line therapy, which is proven, of course, so like lifestyle changes. So if the patient smokes, of course, the first intervention should be on lifestyle, and then PDA5. Second line, for me, it's proven now, PTA, and then low intensity shockwave therapy. And then there is also a third line, which we are working, but it's still unproven, with, for instance, PRP, so platelet-rich plasma, and staminal injection, usually autologous mononuclear cell injection into the cavernous body. This is basically the state of the art of the ED treatment now in 2021.
Thank you, Max.
I don't know if it's 1 hour and 30 minutes. I don't know if they have other questions that I need to ask.
There is one question from Dr. Azim Kamis that is asking, can we use a brachial approach?
You can utilize a brachial approach. You have to understand, however, that you will reach the pudendal, if you utilize the 125 centimeter catheter, with the 110 guide catheter that we utilize, sometimes if the patient is tall, you will not be able to. And on the other, the second part is that you need to manipulate the wire, and sometimes it's extremely difficult to manipulate the wire due to the complex anatomy. My recommendation is to do a femoral puncture. You will be able to have a much better control of torqueability and trackability of the wires. This is my suggestion.
Okay. So are there any other questions from the audience? So we were talking about the dissuasion that is the ongoing trial, but we have not expressed how it's going. While you were out, I was saying that the study is going ahead. It's an investigator-driven study proposed by you, and in this moment, in our opinion, is the biggest one regarding the DEB treatment for ED. And what are your, in general, let's say, feeling and results that you reached during these months? Because now you have many follow-up for patients.
Very, very satisfied, Dario. Honestly speaking, what is really weird. I understand that this is difficult, to believe. But I do outpatient clinic, 3 times per week. 70% of the patients now that I see as a cardiologist are ED patients. Due to the fact that, in my country, basically I am the only center offering this type of procedure. I established a very good network with the urologists. They feel very confident that when we treat the patients, we send back to them patient for follow-up. And they are so pleased with the follow-up that they invite me for the guidelines. So having said that, I do believe, and as a cardiologist, I think that there is a lot of field still to explore. We have no idea about the microcirculation in these patients. We do have the opportunity to evaluate microcirculation in the heart. We are talking about INOCA and MINOCA, as you know, they are cardiologists, Dario, so they know what I'm talking about. It would be fantastic to utilize the same, wires to create an index if there is a microcirculation problem with this patient, because you have to understand, you have seen the results, 30% after the procedure does not improve. Why? We don't know. We really don't know.
Okay. And yes, Max, move on.
No, this fibrosis of the cavernous body, honestly speaking, I don't know. I don't know.
Yeah. And from the audience, arrive another two questions. One is what we would do for females, and who is the best person that can start the program in Egypt? Because in Egypt there are vascular surgeon, is a vascular surgeon domain. So maybe your experience in the field in Italy makes sense to.
This is a good question. It's a vascular domain because they believe that we are talking about the hypogastric. So they are usually, treat the hypogastric if they have to place an EVAR. They believe that they have to embolize the hypogastric if there is involvement with a AAA of the external iliac, so they have to land in a zone and they need to embolize. We're not talking about the hypogastric. You enter the hypogastric, but you go far down. They have no clue about dental arteries, okay? And it's exactly the same size of coronary district. They are not used to utilize 0.014 wires, except for BTK sometimes. They are not used to coronary material, so they will open an over-the-wire balloon and not a monorail balloon, as we do in the coronary district. And these are all material that we utilize in the coronary. So the Magic Touch ED, it's a monorail balloon. It's not an over-the-wire balloon, okay? So I do believe that, as a cardiologist, perhaps now there are some vascular surgeons attending the webinar, but I do believe that, cardiologists are able to do this type of treatment, as well as interventional radiologists, due to the fact that an interventional radiologist who is acquainted with the prostate embolization, it's just the artery a little bit, on the right from the prostate artery. So they will be able, to understand what they're doing and what they have to do. This is what I think. But I would establish the network with the urologist first.
Exactly, this is important point, yeah.
The andrologists usually are the one, because, you will realize that urologists are more surgeons. They are acquainted with prostate cancer, kidney cancer, this kind of stuff. Andrologists, they treat a lot of patients for ED. So urologists, they of course see patients affected by ED, but the core business is an andrologist. So I would establish a good network with both of them. You can involve a vascular surgeon at the beginning. They will not be interested, due to the fact that you have to do questionnaire. You can learn how to do dynamic Doppler. It's very, very easy, the dynamic Doppler. You go 2 times to a neurologist clinic, they will show you how to do a cavernous injection. Very easy to do a cavernous injection. And then you can measure the flow. I mean, if we are able to do echocardiography, we should be able to do a simple pudendal Doppler.
Yeah. Good. So I think that till now there are no other questions. So I want to thank you all and thank you, Max, for your time. You can
give them, my email if they need, they can run privately, whatever they want,
Yeah, for sure.
We will start, some live cases, webinar with live cases. So it would be nice for them to attend one of them so they can see the procedure live and they can ask questions. They will see the difficulties you may encounter during this type of intervention.
Yeah, for sure, it's really useful. For this reason, at Concept Medical, we are going to, for sure, extend the invitation once we plan some live cases in the next upcoming, let's say, months. But if there is curiosity by the audience and so on, we will circulate your email. Maybe you want to show also the website of the ED Academy that is related to what, as let's say, doctors, you are trying to put as hope also for patients, because this is
and you can provide them also with the book we wrote.
Exactly. This is an important point, because thanks to the experience you collected in the last 5 years, and also thanks to the cooperation with many important doctors like Professor Dian and other doctors, you realized a book that can explain all the stuff regarding what are the anatomy, what is the main, let's say, advantage thanks to the treatment with the DEB, the differences with the DES, penile implantation, and so on. So maybe we can give them the opportunity also to receive this book, because it's a really good point, academic point, and also practical point. Yeah. So thank you again, Max, for your time, and thank you all to be here. And we hope to have very soon a new webinar just to extend what has been explained in theory today. And we will send as a follow-up the email of Max and our contact, just to let you have an additional point of connection with Professor Sangiorgi. So thanks to all. Now it's almost 8 o'clock in Saudi Arabia and Egypt. So have a nice evening ahead and have a nice weekend ahead. Bye.
Bye.